say that, Dr. Mukherjee, if we get the HbA1c down by 1%, will it reduce my cardiovascular risk? This is again epidemiological data. Kamlesh Kunti has done it, not a randomized controlled trial, which tells you that if you get your HbA1c below 7% in the first year of diagnosis. So diabetes is like infections. Get the right antibiotic at the right time. Diabetes is like accelerated hypertension. When the patient comes to emergency, you give 3 drugs to get the blood pressure down rapidly. Diabetes isn't disease like that. Get your HbA1c down to goal within 3 months, 6 months, within a year. Don't wait like it's a long drawn test match, 5 days you have. Diabetes management is a T20 match. Every ball counts. The majority worldwide fail to reach glycemic target, and that's why we need a paradigm shift. As I told you, less than 20-25% people worldwide in 2024 have HbA1c below 7%. We are failing somewhere. This is the data. This is the Discover trial. There are many trials, whichever one you want to take. Discover is the latest one. And if you see in India, there are about 1,900 patients. And if you see people with HbA1c more than 9%, almost 1/4. So we need a paradigm shift. We need to move away from one drug, two drug, metformin, sulfonylurea. No, please. First, educate the patient, get them to do lifestyle modification, and think of early combination therapy. So what is that? So initially I discussed why we need early combination therapy. Now I'm going to discuss which combination therapy. This is a controversial area, not much data here. What we do now is treat to failure sequential add-on therapy. We keep adding one drug and we wait. This is the famous trial which was published way back ago, DOP trial, which tells you, I don't have much time. This one slide will take me 5 minutes. If you want to read, you can read. Look at the failure rate. Glyburide is sulfonylurea, there's a 34% failure rate. Take metformin, 21% failure rate over 5 years' time. You say, Dr. Mukherjee, this is old hat. You're talking about the DOP trial which was published long time ago. No, look at the GRADE study. I hope all of you know GRADE study. If you don't, please go and read. GRADE study was the recent study, most study. There again you see the same Nike sign. You get the HbA1c down very nicely in the first 6 months' time, and these are good drugs now. You're dealing with glargine, liraglutide, glimepiride, sitagliptin. They all fail. They all fail. Why? Because this GRADE trial was metformin plus one drug. So if you do metformin plus one drug, okay, if you see the patient for 6 months, you can pat your back, ha ha ha, I've done a lot of good things. But if you follow this patient for 5 years, sorry, you have not done a good job about it. So is there any evidence, you're talking too much, Dr. Mukherjee, about intensive therapy. Is there any evidence to show that intensive therapy works? 100%. There are a lot of studies. These are the famous insulin studies. These are old hat now. They started in 2007. This is the meta-analysis which came in Lancet. Again, very difficult to go through all the bars here. What you can see is basically the Wang et al. Trial. Just read the top. The proportion of participants in drug-free remission 12 months after starting intensive insulin therapy. You and I can't do this. This was the research study. Every type 2 diabetic patient diagnosed was admitted, given intravenous insulin for 14 days. They got the HbA1c down to below 6.5, then they stopped the insulin, followed the patient up for 1 year, and they showed that half of them were within normal blood glucose ranges. So which tells you that if you can get early good glycemic control, if you reduce the glucotoxicity, and along with glucotoxicity, if you're giving insulin, you're reducing lipotoxicity as well, you're protecting the beta cell. Never think about reversal. It's always remission. That's one thing to note. So short-term intensive insulin therapy can improve the underlying pathophysiology of early type 2 diabetes. Why? Because it is reducing the glucotoxicity, anti-lipolytic effect, anti-inflammatory effect, and anti-apoptotic effect. So think of doing combination therapy. Dr. Mukherjee, we can't do insulin therapy for every type 2 diabetic patient. I agree. I also can't do it. So what about oral hypoglycemic agents? These same trials, along with insulin, had an oral hypoglycemic arm. Here they gave metformin and gliclazide. Unfortunately, that time when these trials were done, the newer molecules, DPP-4, GLP-1, were not available. And even here you see 26%, 1/4 were free of any treatment at 1 year. So what is the evidence for initial combination therapy? Do we have evidence? Yes, we have. All of you have heard about it. I'm just synthesizing it in one slide. Dual combination therapy. The biggest data you have is from Verify trial. There were other trials done, Cosmic trial, metformin plus linagliptin, metformin plus SGLT2, etc. But the one which was done properly was the Verify trial. Those of you who don't know Verify trial, please go and read. I can't take you in the next 30 seconds what is Verify trial. Verify trial was basically patients with almost new onset diabetes, 1 to 2 years of type 2 diabetes. There were 2 arms. One arm got metformin, the other arm got metformin plus vildagliptin. They were followed up for 5 years. And what it tells you here is that if you're using combination therapy, the risk of failing was HbA1c going above 7%, was 43% at 5 years if you're using metformin and vildagliptin, whereas if you're using only metformin, the failure rate is 62%. Even now you see that still 40% people are failing. Having said that, if you start with metformin and a DPP-4 in a verified trial, you get more people maintaining the glycemic target over a long period of time. What about triple combination? Do we have studies? The best study is the EDICT trial. Those of you who are students here, I'm very glad to see there are a lot of younger people in Telangana. Most of the places where I give talks, they're all people my age. But I see a lot of young people here. So EDICT trial is a trial that you need to read. This is the initial combination therapy with metformin, pioglitazone, and the GLP-1. Why exenatide was used? Because when Defronzo designed this study, the other GLP-1 receptor agonists were not available in the market. So exenatide was the first one, 2005, it was introduced. So what he did was, the initial ADA guideline or ESD guideline was stepwise therapy. Give metformin, you fail, give sulfonylurea, you fail, you add basal insulin. And the other arm, he gave metformin, pioglitazone, and exenatide. And it was nicely followed up. And what they found, why did he choose this combination? Because in the early insulin therapy, what they said,